psyched. I'm psyched about this one. So for everybody that is joining us, especially those joining us for the first time, I'm Erin King-Mullins, colorectal surgeon, also known as Dr. Tissue Touchup, and I am continuing our Love Below series this evening with Dr. Mitzi. So introduce yourself and tell us all about what you do.
Absolutely. Hi, everybody. I am Dr. Mitzi, the nerdy neurologist. My name is Mitzi Joi Williams. I'm a board certified neurologist and fellowship trained neuroimmunologist. And I help to educate people about chronic neurologic conditions. I own my own practice right outside of Atlanta, Georgia, and do lots of education about things such as this, which help people to better understand their brain health. And I'm really excited to be here tonight with you, Dr. Mullins.
Thank you so much. So to kind of bring you up to speed, I'll give you the rundown of some of the different folks we've interviewed on this
Yeah.
Love Below series because,
Uh-huh.
it takes a village
It
to
does.
take care of patients. And,
Mhm.
so many things in medicine these days happen in isolation. And the point of this series is to really nurture the collaborative efforts and the multidisciplinary approach that we have to take the medicine. So as a colorectal surgeon, I mean, everybody always talks about, cancer, right? And so there's the
Mhm.
oncologist, the radiologist, there's everybody, but there's so many other disease states outside of cancer for
Yeah.
colorectal, especially in women, pelvic floor. Um,
Mhm.
so we've talked to a fibroid endometriosis specialist, a pelvic
Mm.
floor physical therapist, a
Wow.
gastroenterologist. Um,
Yeah.
last week, so I think there's going to be a lot of overlap. Last week we spoke with a urologist and a
Mhm.
female pelvic floor reconstructive surgeon who's based out
Mhm.
of Chicago, Dr. Finwa Millhouse. And so we
Mhm.
talked about incontinence and like kind of
Mhm.
sexual dysfunction and all of those
Yeah.
things. So I think there's going to be a lot of crossover and overlap with our conversation today.
Absolutely, absolutely. Yeah, I mean, so I think the interesting thing that people often don't recognize that some of those colorectal symptoms or even urinary symptoms can be related to dysfunction in the brain. So I have so
Yep.
many people that come in and are like, okay, well, I was peeing on myself, but I thought it was because I had babies. I'm like, no,
Hmm.
no. I mean,
Yeah.
it could be partially, but what you're
Right.
describing is not due to that. So I
Right.
think that, this is a really important conversation because the brain and the nerves innervate, right, and
Hmm.
activate many of those areas of the body and the gut that help people to understand that sometimes there can be something else going on that's bigger than us
Hmm.
just thinking we ate something bad or maybe, we're allergic to something. It really can be a brain or a central nervous system problem.
Yeah, and that's so right. And it's so funny, even patients come to me sometimes, and sometimes their physicians haven't quite connected the dots. And,
Yeah,
it may be that they haven't really voiced their symptoms fully to their
right,
physicians, or
right.
again, sometimes we just isolate different organs
Hmm.
when we're treating patients. And so many times a patient will come in with, gastrointestinal pelvic floor, incontinence symptoms, and I'll just
Hmm.
run down a few things. I'm like, okay, do you have any history of this, or any autoimmune diseases?
Hmm.
Anybody in your family with any autoimmune diseases? Or do you have diabetes, and do you have
Hmm.
neuropathy or something from? And they're like,
Right.
hmm. Like, or, have you had any back injuries? And lo and behold, they had 10, 12 fused disc in the lumbar, and they see in chiropractic and ortho and everybody. And I'm like, yeah, that's where the nerves come from.
It
So
is. Yeah, it's all connected, right? And so,
yeah.
as you said, I think it's important to have doctors who are willing to try to put the pieces together, right? So, I deal a lot with bowel and bladder issues as a neuroimmunologist, which basically is a big word for I treat a lot of people with multiple sclerosis and
Hmm.
other related diseases. And so, I also treat a lot of people with degenerative disease, arthritis, pinched nerves, right? If a nerve is
Hmm.
pinched, it can cause some of those symptoms. And so it really is a matter of somebody kind of sitting and saying, okay, let's back this up. Let's see what all is going on and let's see if we can put the pieces together. Sometimes it's multiple different things, but oftentimes there may be, one or two causes that are leading to the symptoms. And we can identify that if we just kind of take a step back, a 50,000 foot view,
Yep.
and just, kind of go through what's been going on. And then it all starts to make sense. Whereas our patients, they go to the ER, they go here, they go there, and they were like, somebody said nothing was wrong, or somebody said I was just getting old. And I'm like, well, that's not because you're getting old.
Yeah.
So So, I think it's really important to recognize that, there is this gut brain axis, right? So
Mm-hmm.
the brain and the gut communicate with each other. And the nerves, we have our, autonomic nervous system, which is
Mm-hmm.
our, we call the sympathetic nervous system, which is our fight or flight. People think about that when they think about an old lady that lifts a car, although I've never seen an old lady lift a car with a stressful situation, but theoretically that can happen, right?
Right.
So that's your fight or flight. And then there's the autonomic, so then there's a parasympathetic nervous system, which is what I call our rest and digest. And so the rest and digest part is a part where the brain kind of helps the gut to, digest food properly, also helps the blood flow to go properly. And if that system is interrupted, people can have lots of issues like constipation or
Yep.
diarrhea, right? And they don't relate it to a nervous system issue. Also, there's a lot of research now looking into what we call the gut microbiome, right? So all the bacteria and bugs in the gut, right? And
Yep.
how that actually educates your immune system. And so there's a lot of question about, are the foods that we're eating, or is the chronic stress of our body that we're experiencing causing things like inflammation that leads to autoimmune disease? Are we educating our immune systems to be overactive because we're
Right.
eating all these ultra processed foods? So it really is a very complex but very vital relationship that tends to get overlooked, because usually when we think of the gut, we just kind of think of it as this separate thing that's just sitting there, and
Yep.
somehow we're always doing something to irritate it. But there is really this intricate connection. Something that's also really cool or interesting is that the gut makes most of a neurotransmitter called serotonin, and that's one of our feel good neurotransmitters. So if there are issues with serotonin or issues with mood, that can be affected by the gut. So there really is a very complex relationship. Like, we almost like cousins, the
Right.
neurologist, we like cousins.
Mm-hmm. Yeah.
Right. Because I'm like, I think that's your nerves, sugar. Sometimes it's your
Right.
mental nerves, but sometimes it's your actual nerves that are
Yep.
causing the issue. So that's
Yep.
really important.
Yeah, and when you talk about, how the gut trains your body
Yeah.
to receive certain things, and
Yeah.
people just a lot of people just don't really understand the sensitivity of the intestinal system, or
Yeah.
they don't think of it beyond, like, yes, we absorb nutrients, right? But so
Yes.
many other things are absorbed into
Yes.
your bloodstream that can
Mm-hmm.
impact. I mean, the number one thing I always equate it to is, just think, like, if you drink enough alcohol, you get drunk, right?
Right.
Your blood alcohol level
Right.
goes up. So what you consume, it's in somehow, some way, makes it to your bloodstream.
Absolutely.
Um, and then when you break out down the official term of autoimmune, like, your
Mm-hmm.
body has developed some sort of immunity to itself. And as
Mm-hmm.
you said, there's so much research and things like that out there, just trying to figure out what those triggers are. And we're
Mm-hmm.
getting more and more along the lines of, how the gut contributes. And when we talk about the good and the bad bacteria, having the right amount of good bacteria to kind of
Yeah.
help break down certain things that we consume, but
Mm-hmm.
also help fight the bad bacteria that can cause disruptions in how we absorb things. So it's just going to be amazing to see, because, like, well, remember, I mean, I guess, remember when it was really a fad? I mean, it's still, I think, popular now, but it was really a fad several years ago. People eating based upon their blood type, and they're like, "Oh,
Absolutely.
I'm on
Yeah.
the B type diet. I'm on the O type." I
Yeah.
mean, there's science behind this,
Right.
understanding how our bodies work, antibodies, good, bad bacteria, all that stuff.
So I'll tell you
Yeah.
about this study that absolutely blew my mind. I was at a conference, so neurologists are a little bit, so neuroimmunology, where we talk about MS, which is an autoimmune disease affecting the central nervous system, is a little bit behind the eight ball in talking about nutrition and, gut health and things like that. And so there was this study that I saw at a poster I saw at a conference maybe about 10 years ago. And they did a study where they looked at different animals. I'm not going to name which animals because some people get grossed out. But they did a study where they looked at the microbiome, right? The regular microbiome in these animals. And so when they had the regular microbiome, all the regular bacteria there in the guts that are in humans, they could basically induce a state that looked like MS in these animals. When
Mhm.
they removed the microbiome, they could not induce that disease. And I was like, okay, there's
Right.
definitely something to this diet and to how the gut functions. And I think that unfortunately with medicine, with things like diet and how we should be eating and how our foods are really affecting us, we're a little bit behind the eight ball, right? So I'm a person who believes in medicine. Absolutely, I'm a physician, but I also believe that there's a lot of other things that we need to study. And unfortunately, because there's not a lot of money in studying diet, it's hard for people who are doing that type of research to really get the answers that we need, because you have to have funding to get research done. And funding is usually behind more treatments or procedures versus those diet things. But I think that it's a really exciting time because now we're having more people who are focusing on this. And I think we're going to see some exciting research in the coming years about how what we're eating really impacts. I think we know it implicitly, right? We know the
Right.
difference we feel when we eat certain things. We know
Yep.
how, we know what makes us stopped up, right? When we eat that fast food versus when we eat some quinoa, right? But I think that we're really going to get to the real science behind how the things that we are consuming are affecting the immune system, affecting our gut,
Right.
and how that affects the central nervous system as well. I think it's going to be really fascinating.
Yeah, yeah, there's so much on the horizon.
Yeah.
Um, so let's go a little bit further down below,
Okay.
beyond the gut per se, as far as for
Yeah.
when we talk about the stomach and the intestines. Let's talk a little bit more about the colon and the rectum and how,
Mhm.
when I think of some of the overlap that we have as a colorectal surgeon and a neurologist, neuroimmunologist. There's the a lot of times women come to me, and more than just women, but I see a lot of women. Women come to me with that dysfunction, like they
Mhm.
can't evacuate well or they
Yes.
can't control their bowels.
Hmm.
So I think there's a lot of overlap, obviously, with the nervous input to the sphincter muscle mechanism for them to
Absolutely.
be able to evacuate appropriately. But then there's also the impact of the colon um, from medications that patients may take for some of their neurological disorders. So can you kind
Hmm.
of touch on a little bit of those two things and kind of how they interact, since we're talking about, the love below?
Absolutely. All right. So we're getting down to the bottom, right? The bottom,
Yes.
right? So I
Yes.
think that it's extremely important for people to recognize that when they come, for instance, to their doctor with certain symptoms, we have to look at the big picture. So as a neurologist, when one of my patients who has a chronic neurologic condition comes to me and says, "Hey, doc, I'm having trouble controlling my bowel," it is not an uncommon issue where people have incontinence, meaning they have accidents, they're not able to get to the bathroom in time. Sometimes it's an issue of what we call urgency, meaning they get the sensation that they have to go at the last minute. And if they're literally not right there at the bathroom, they're going to have an episode of incontinence. And then other times, depending on how severe their nerve dysfunction is, they can have no signal and they're just kind of sitting there and it can just happen. And so this is a real issue that affects people's daily lives. Obviously, I have many people who, until these symptoms are treated by specialists such as yourself, they may not even want to go outside, right? Because they don't know, or they, may be 30 and have to wear adult diapers. So there's a lot of things that go into it. So I think the first thing is recognizing that this can be an issue due to nervous system problems. The most common issue where we see this happen is when people have damage to the spinal cord. Now, when we think about the brain affects everything, right? All the nerves are kind of in the brain and then they come down into little tracts and hang out in the spinal cord, which is a really thin
Right.
area. I think that the important thing to recognize is that the spinal cord, although it's very small, has a lot of function packed into a small space. And all the nerves that go down to the arms, to the legs, to the sphincters, they all have to go through the cervical spine. So pretty much if you get a spot right here at the top or damage here, it can affect anything from that level down. Also, if you have areas that are affected either by diseases like MS or their spinal cord damage, like if someone has a slip disc that's pressing on the nerves or herniated disc, whether they're cervical, thoracic, which is the middle, or lumbar spine, all of those things have the potential to affect bladder and bowel dysfunction. And
Yep.
so, we first have to try to identify where the issue is coming from.
Hmm.
Because sometimes, if it's something like a pinched nerve or herniated disc, we can get the surgeon to fix it, right?
Right.
And hopefully relieve some of that pressure. But if it is something that maybe cannot be fixed, right, like, either the damage has already been done by MS or something like that, then we lean to our colleagues to try to help us. The other thing that we look at is that sometimes the medicines that we give, we always have to walk this fine line between benefit versus risk, right? So every medicine is going to have a side effect. And so if we give you a medicine that helps, pain, it may cause you to be stopped up. Right. And so we also have to kind of take a look at what are we giving that may be impacting this issue or that may not be giving you enough time. So on the neurology side, we do a lot of counseling about number one, trying to identify where the issue is coming from. Is it
Hmm.
due to autoimmune disease? Is it due to a herniated slip disc or some other type of spinal cord dysfunction? And then if we identify that, we try to address it. And then the second piece is, we do a lot of counseling in my arena about things like, okay, how can we maybe retrain ourselves, almost like potty training again, right? Going at certain intervals. Are there things we can do to bulk up the stool, like eat some extra fiber, right? To try to
Right.
give you a little bit more time. How can we alleviate constipation so that you don't have, stuff running around? Sometimes people have issues because they actually are constipated and then there's, other stool that kind of goes around it and cause an issue, so we
Right.
try to look at all of those things and of course enlist the help of our colleagues like yourself, to help us to, manage these issues as well.
Yeah. And you just made an important point. And why it's so important for patients to discuss their symptoms with their physicians and also for
Yeah.
their doctors to be in tune with what they're saying, because sometimes there's conflicting evidence or
Mhm.
two things can be true at once. And
Right.
one of the things we see sometimes is, patients with diarrhea because they're actually so severely constipated.
Constipated. Yep. Absolutely.
And it's
Absolutely.
just like, wait, what? Huh? So,
Right.
so, so the concept, so, if someone's been constipated so long, the bowels aren't moving. And so you have, sorry, I'm going to get a little bit graphic, but just this hard, firm, old stool that's just kind of sitting in the colon. And it's
Mm-hmm.
kind of to some degree partially blocking the colon.
Mm-hmm.
Now, the patient, the only thing that can get past that area is liquid or something really soft. So now
Mm-hmm.
every time you have a bowel movement, every time you sit on the commode, things may be shooting out. So
Mm-hmm.
it may experience explosive diarrhea,
Mm-hmm.
or it just means you're just like, oh, it's diarrhea, it's only liquid. I can't, pass a firm stool because that's
Mm-hmm.
the only thing that kind of passes by. Or there's also that concept of overflow incontinence.
Mm-hmm.
Sometimes patients don't really relate that, and it's very similar to, the bladder. We all know that if we wait too
Right.
long, your kid wait too
Right.
long, then
Right.
something gonna leak out. Like there's only so much
Exactly.
capacity. So very similar
Exactly.
for the rectum and the colon. Like if you're
Mm-hmm.
so constipated, it can get to the point where the colon is overfull, and so
Mm-hmm.
now that is what's causing your incontinence. And now we got to look back at, okay, what's causing that chronic constipation? Is it medications that you're on?
Mm-hmm.
Is there generalized slowing of that gastrointestinal system?
Mm-hmm.
Because patients will come to me with this entity called colonic inertia, right?
Mm-hmm.
So they've been sent to me because their colon doesn't work, right? So
Mm-hmm.
all these tests are valid. They've tried all these medicines, and so one of the first in the treatment for colonic inertia is removing the colon. And no, not this segment over here that might be a little extra long, and
The
over here,
whole
no, no,
thing.
no. The true textbook
Wow.
procedure is removing the entire
The
colon, and you
whole
can
colon.
the
Wow.
whole thing. And so
Mm.
you can either give someone an ostomy made out of the small intestine, or you can kind of
Mhm.
reconstruct a rectum and hook it up down there, like making
Mhm.
a new configuration of the rectum with a small intestine. But the long and short of it is, if you haven't done a thorough evaluation of someone's gastrointestinal system,
Mhm.
you
Mhm.
may make them worse because,
Right.
excuse me, it's important to understand, is there a global dysfunction of, the stomach,
Mhm.
excuse me, what we call gastroparesis,
Yeah.
or if there's, delayed gastric emptying, or the small intestine processes things too slowly, then those are reasons it's going to get slow to the colon, which means it's going to
Mm-hmm.
be slow to get out of your body. So if I take
Mm-hmm.
out your colon, I haven't helped you.
I haven't helped you.
Excuse me.
Mm-hmm.
So maybe throw out some excuse me while I'm trying to
That's okay.
not hack up a
You
lung
so so so
from the thing um from the allergies, but maybe
the
touch on a
pollen.
few medicines that are just like really key and known to affect, how the bowels move that maybe you interact with.
Absolutely. So I definitely want, I think that's important. I wanted to touch on, I was thinking about the perfect analogy for what we were talking about with overflow incontinence. So I've
Mm-hmm.
got two kids. I know you got kids too. So,
Mm-hmm.
I tell my son to go brush his teeth. He said he doesn't want to brush his teeth because the toothpaste tube is stopped up. So basically, when they leave that toothpaste tube open, it gets hard at the top and you got to squeeze and squeeze to try to get some toothpaste around. And when you do finally get some toothpaste around that hard block, it's going to probably squirt you in the eye. You know what I mean? And so to me, that was actually the analogy that came to mind when you were talking about the overflow incontinence. I thought about that toothpaste because literally I was like, dude, just take the time and dig the hole out of the toothpaste and then the toothpaste will work,
So
but
disinfection, we got to
right,
disinfect patients
right.
sometimes.
Just
Got to
just
open it up.
disinfect the toothpaste tube, right? And then you can use the toothpaste. But I thought about that analogy. But yeah, so some of the medicines that we typically give, so very commonly pain medications, right?
Yep.
So with neurologic conditions, people deal with a lot of pain. And so many of our pain medications sometimes are, medications like our gabapentins, or particularly if people take narcotics, right? So after you have a surgery, if
Yep.
you have some pain and you have to take a narcotic, that's a really big one that causes a lot of constipation. So a lot of our nerve pain medicines, a lot of our spasticity medicines, baclofen, all of those, people can report that they feel like things slow down, and they feel like they're starting to have some constipation related to that. But also, I think it's important to recognize that constipation by itself can be a symptom of multiple sclerosis, right? Just
Mm-hmm.
having a CNS autoimmune disease can impact that system and actually cause things to slow down, even if you're not taking medication. But really, our pain medications are some of the biggest culprits that cause things to slow down and get in our way.
Yeah, yeah, that's so key, so key. So
Mm,
tell me a little bit about, in what situation that you might find yourself referring a patient to a colorectal surgeon, or, what what signs and symptoms should patients who have neurological dysfunction,
mhm,
look for to make sure that they're making their doctors aware of to say,
mhm.
hey, maybe I need a higher level of, therapy and evaluation.
Absolutely. So I think the first thing is, as you said, you've got to be comfortable and tell your doctor what's going on with you, right? So I
Yep.
tell people all the time, listen, there is no shame, honey. People have told me all kind of stuff that I can't say on IG Live. So, I think it's important that if it is impacting your daily life, regardless of the symptoms, it never hurts to mention it to your neurologist or to your primary care physician, whoever you're seeing. But if you have a chronic condition like an autoimmune disease, please, please, please talk to your specialist if you're having these symptoms. There's nothing shameful in that. And we always want to try to intervene before things get so severe that you got to go to the hospital and get your colon removed, something crazy like that.
Yep. Yep.
So
Yep. Yep.
that's number one. Number two, as a neuroimmunologist, I manage a lot of different symptoms. So I'm usually real comfortable. I have my conversation about what we do about constipation. Diarrhea typically is not my wheelhouse. So if you running,
Yeah.
that ain't got nothing to do with me. So that's an automatic referral. If you run into the bathroom, that ain't my fault. So if you got
Right.
diarrhea, I'm sending you to somebody, okay? Because that's not a typical symptom. So stopped
Right.
up, we kind of work through it. We add the benefiber, we add the water, we do all the things. But referrals definitely, if you're having incontinence, I think that's an automatic referral, right?
Yep.
If your neurologist or whoever has investigated, you don't have like an acute surgical issue that needs
Hmm.
to be addressed, I'm going to refer everybody that has incontinence incontinence. So if you have urinary incontinence, I'm going to send you to the urologist to get a workup and to get appropriate treatment. And then if you have bowel incontinence, you get an automatic referral to a gastro specialist, whether it's a colorectal surgeon or a gastroenterologist. So incontinence is a do not pass go.
Yeah.
Diarrhea is a do not pass go. You got to go see somebody because that ain't my fault, right?
Yeah.
And then on top of that, I'm usually a very practical person, right? I recognize that I manage many different things. I treat bladder issues, I treat UTIs, I treat nerve pain, I treat seizures, I treat all the things, headaches, I treat all of that. But if we have tried what I feel like is reasonable, right?
Hmm.
And it's not working, I'm not going to keep playing around with you, right? I'm going to send you
Yeah.
to somebody that does that every day and that has that expertise, right? So if I tell you, let's drink the water, we're drinking the water, we're doing the fiber, we're eating the roughage, and it's
Right.
not working, and we give it like a couple of months, we give it like 6 to 8 weeks to see how it's doing. And if we check back in and it ain't working, you're going to go see somebody. All right.
Yeah.
So I think it's just really important for us to recognize as physicians to know what you don't know, right?
Yeah.
And if somebody is stopped, I'm not going to play around with you for 6 months trying to figure out, I'm going to send you to somebody that has that training and has that expertise like you, Erin, and let them help me to best treat you. And sometimes it's a matter of a referral, and then you say, okay, we need to put you on whatever, Amitiza. That's
Right.
the only one I know, right? I don't know anyone. They put you on that, you stable, I'll prescribe it, right? But I have a very low threshold for calling in help if it is something that, we've done our reasonable things for and they're not working. Because
Yeah.
ultimately, we want people to live well and we want people to feel well. And kind of giving you the runaround for 2,000 years is not going to help you in your everyday life. I'm going to send you to somebody that knows what they're doing.
Yeah. Definitely. So for those who are
Mhm.
just tuning in, just a reminder, Erin King-Mullins, Dr. Tushy Touch-Up, colorectal surgeon. We are talking to the nerdy neurologist, Dr. Mitzi Joi Williams, neuroimmunologist, treats a lot of multiple sclerosis. I can't talk today.
That's okay.
MS, okay?
MS.
MS.
Uh-huh.
Um, but
Yes.
we're just talking a lot about the overlap between gut health and neurological health and
Hmm.
dysfunction. And she was just mentioning, some of the reasons why we may refer to each other. And I want also, anybody who's watching to know the fact that we do also have like more objective ways that we can measure your symptoms and what they may be
Yeah.
caused by. So
Yeah.
it's not always just saying it's, your neurological dysfunction.
Hmm.
It can be a compounding of you are taking medicines that slow the bowels down. You've had, you've been pregnant or had a vaginal delivery, had a tear, you've had a back injury or something, and you have a neurological dysfunction. So there's different testing. There's MRI, there's defecography, there's manometry, there's
Hmm.
rectal sensation tests. There's a
Hmm.
lot of things that we can do to be um, more precise in
Hmm.
diagnosing exactly what the dysfunction is before
Hmm.
we render and deliver therapies and treatments. And so
Hmm.
again, just want to make sure that our patients are advocating for themselves and, just being willing to just say something so that we
Hmm.
can point them on the right path, because
Hmm.
some will be medically managed, some will be surgically managed, and some will be managed with physical therapy, and some
Hmm.
will be mitigated with dietary changes.
Hmm.
And so I'm super excited. We should be making some more formal announcements soon. I do have a registered dietitian who's going to be working, well, who is working with the practice. We
Yay.
actually, at your event that I spoke at, that's how I ended up meeting her.
She's
And so look,
amazing.
yes, so be
Yeah.
on the lookout for those announcements,
Hmm.
for, because again, we have to take this, patients have to take a multidisciplinary approach just as much as us.
Hmm.
And I know you mentioned, water and the fruits and veggies and the benefiber and the
Hmm.
amatiza, but I
Hmm.
think one of the things that patients and maybe and even other physicians sometimes lack in their comprehensive care of these symptoms, we
Hmm.
start out, okay, patients, I'm constipated, can't move my bowels. So number
Hmm.
one, okay, what is your definition of constipation, right? So a patient
Right.
may be saying, well, I go every day, but it's hard.
Hmm.
Or I go every day, but I feel like I can't really push it out. I'm pushing. Or they're
Mm-hmm.
like, no, I can only go once or twice a week. So those
Mm-hmm.
are the keys. We have to make sure, like, what is the definition of
Right.
constipation? Because so many people have different definitions.
Mm-hmm.
But then when we go through that process of the more conservative or medical managements, we say the water and the fiber and the activity. And if that
Mm-hmm.
doesn't work, then we may say Miralax, Benefiber,
Mm-hmm.
or some of the prescription medicines.
Mm-hmm.
And we got to remember, you can't stop doing number one and number two. You can't not now just stop drinking the water and stop eating the fiber and then just
That
switch on
part.
over to the prescription medicine.
That part.
It's a layered approach. Like you do all this
Say it
and then
again for the people in the back.
you add. You can't take this away because guess what? You set the foundation. So
Right.
like that game Jenga, you set that foundation, and if you
Right.
pull the wrong thing out, it all falls down.
It
So you
all
can't,
falls down.
it's an additive effect. So we just want to make
My
sure everybody knows that.
my favorite Dr. Mitzi-ism, that's what I call it now, is that I always say there's a part you play, there's a part medicine plays. There is no medicine that gets rid of the part you play, right? So we can give you some medicine to make you go, but you still have to do the lifestyle stuff. There is never a time when you don't have to do lifestyle modification, regardless of what condition we're talking about.
Right,
There's always a part that you play, drinking the water, eating the well balanced diet, if we need to add the fiber, but there's always that part that you're responsible for, in terms of your lifestyle and your daily habits that is going to contribute to you doing well. And I think
yep.
that we forget that part because, we live in a culture where people want a quick fix. And so they're like, hey, doc, I got this. Give me a pill. And I'm like, well, why don't we drink some water? Yeah, but I don't want to do that. Give me a pill. I hate water. And I'm like, okay, well, let's
Yep.
drink the water first. You know what I mean?
Right.
So,
Mm-hmm.
I think that it's really key that people take ownership of the part
Yep.
that they play and recognize that the things you do on a daily basis add up, and they add up in a good way and they can add up in a bad way. And we don't expect everybody to be perfect, right?
Right.
Nobody expects you to drink 5 gallons of water a day, but we
Right.
try to do better and we try to do the best that we can. And sometimes we're not doing enough and we're trying to
Yep.
depend on a medication to do it for us instead
Yep.
of us helping ourselves.
Yeah, so I'm gonna give you my water anecdote and feel
Okay.
free to use it. Feel free to
All
use
right.
it. I
Give
may
it
have
to
to
me. Cause
trademark it. It's the Aaronism. So this is what
right.
I tell patients. I'm like,
Let's
just think
hear it.
about, if we're talking about going to the bathroom, right? So you go sit on the toilet, poop all you want, turn around, push that handle. If there's no water in the tank, what's gonna happen?
It's gonna be stuff.
Nada.
Nothing.
Same thing in your body. So I mean, so it's pure mechanics.
There
There's
it
nothing
is.
around that. Like you can put
There
a
it is.
pill, you can just put the pill right there, sit it on top. It's gonna sit right here, right on
It's
top.
sitting right there. It
So
ain't going nowhere. So
not going
I will
to.
give you credit the first time, and then it will become a doc. No, I'm just playing.
Okay.
Then it
All
become a
right. All
Dr.
right.
Mitziism.
Don't make me call over there. Don't let me call over there and see what's going on in the Joy Life Wellness uh office.
But it's so
Um.
true, right? It makes
Yep.
sense. And when you explain it like that, it makes sense. And so I'm like,
Yep.
okay, well, let's make it make sense because what you're saying ain't making no sense. You need some water. You got to loosen that thing up. It's got to be able to move. You know what I mean? So, I think I, I've really been excited about, is, knowing that we have so much more specialty care, so I've been treating neurologic disease for almost 20 years. And there was a time where, the neurologists, we were just trying to do everything. We would send
Hmm.
somebody and they would say, it's your MS and send them back to us. So I'm really excited to see that, there's more testing that can be done. There's more assessment that can be done. And there are better solutions for our patients because we really just, it would just be like, sis, you got to go get
Yeah.
disinfected every once in a while and let the odds forever be in your favor, so
There it is. Yeah.
may the odds forever be in your favor. So
Yeah.
I'm really excited, about your specialty, and about the work that you do that really helps our patients. So let me ask you this. I know this is your show.
Yes.
Let me ask you this. Okay, so they come to the neurologist, they say, Dr. Mitzi, I'm running to the bathroom, I got diarrhea, or I have incontinence. And I say, you know what? Okay, if you can't feel it, I got to send you to somebody. What happens next in that journey, right? So they've seen the neurologist, we've done the MRIs, we've done the testing, right? And we say, okay, there's not an immediate thing here, but we know this is an
Right.
issue. What happens when they come to you? Where do they go?
Sure.
Where do they go from there?
So first thing, just like we say, when we learn in med school, like listen to the patient. So history and physical exam. So I'm really getting a history, like when did this start?
Right.
Okay. And then did something change in your life when this started? Was that a new diagnosis of, your neurological disorder when that happened? Did you get started on a medicine? Did you have a surgery? So first off, like, is there anything that you can think of that happened right around the same time this happened?
Right.
Um, and then getting more definition about around it. Are you talking about like you c- you can feel the bowel coming and you can't hold it back, or you
Mm-hmm.
surprised, you're like, oh my gosh, you go to the restroom and you let loose and you didn't know? um
Mm-hmm.
are you experiencing, you had a bowel movement and then later on you're getting a little bit more leakage later? So
Mm-hmm.
there's a lot of questioning. And then is it mostly solid stool or liquid stool that you're leaking?
Mm-hmm.
Is it gas? Are you then also making sure, are you having urinary incontinence?
Mm-hmm.
And then understanding the full surgical history, birthing history, any, spinal injuries, and, all of that stuff. So thorough questioning and examination. And that can elucidate, certain things. And so you're going to
Mm-hmm.
walk down certain pathways of diagnosis, imaging, ultrasound, colonoscopy,
Yeah.
um, basic rectal exam in the office. This is the
Mm-hmm.
cheapest
Cheapest.
test
Mm-hmm.
that we got out there. Okay. So a
Right.
gloved finger and some lube. So,
Right.
do a rectal exam. Number one, do I feel any
Mm-hmm.
masses or lumps or bumps? When I try,
Right.
naturally, when you try to
Because your
do a
neurologist
rectal
ain't
exam,
gonna do that. I'm just letting y'all know I ain't doing it.
well, I'll need you to job security. Okay. Okay. Let
Right.
me,
You
let
ain't
me,
even got to worry
let's
about me.
but at baseline, can I slip my finger in, or
Right.
like, is it hard? What's the
Right.
resting tone? If your
Right.
sphincter muscles are open, then yes, things are gonna fall out. I ask you to squeeze and push, like, are your muscles doing what they're supposed to do? So that again,
Right.
so all of these things, a lot of so it's funny, and I just recently put a couple of posts on about insurance refusing a therapy for a patient that we're like appealing and appealing. But at the
Mm-hmm.
end of the day, the history and the physical exam, most times gives us our answer
Mm-hmm.
more so than the additional x-rays,
Yes.
tests,
Mm-hmm.
colonoscopies. Those other tests can help us fine tune.
Mm-hmm.
Do we have a global pelvic floor dysfunction that I do need to engage
Mm-hmm.
a urologist, a urogynecologist, a gynecologist
Mm-hmm.
in? So, because there's multiple things that we need to attack at the same time, but
Mm-hmm.
also confirm it. Do we have a mixed dysfunction, or, basically, I got to do it because if I don't do this, then the insurance company ain't gonna approve what I want to do. So here, let me
Right.
just run it up so we can
Right.
document that we did this. So,
Right.
so, so,
Right.
so that's what we're
Right.
dealing with. Yeah.
Right. And I like what you said about mixed picture because I think, something that I usually use the analogy for the bladder, but, certainly the bowel applies too. I usually say my patients fit into one or two categories, either gotta go, or gotta go and can't go.
Right.
And then some people have a mixture of both because they're muscles, right? Those sphincters are muscles.
Mm-hmm.
It is a really I think there are many things that we take for granted that are very complex
Mm-hmm.
processes, right? So
Yep.
even something as simple as walking, right? It takes a lot of processing of the brain and the nerves to tell the body where it is in space, to keep you upright, to put one foot in
Right.
front. Like all of this planning
Mm-hmm.
has to go into place. And very similarly, when we have to go to the bathroom, something got to squeeze and something got to let go, right? And
Yep.
so,
Yep.
if those nerves are not speaking or communicating properly with your spinal cord and in turn with your brain, something is squeezing when it ain't supposed to squeeze, or something is letting go when it ain't supposed to let go, right? And
Yeah.
so,
Yep.
I think that people sometimes don't appreciate the complexity of
Yep.
these functions that we take for granted on a regular basis, even something like
Yep.
swallowing. Many people with neurologic disease or spinal cord injuries will have trouble swallowing. The food got to go
Yep.
in. We got to make sure it don't go in your lungs. That has to be blocked. Then you got to take it down, and the esophagus has to, pull it down by peristalsis. These are really complex processes, and
Yep.
so, it really highlights that intricate balance with the nervous system and these other parts of the body so that, when you want to hold, you can hold it till you get to the bathroom.
Yeah.
And then when you want to let
Well,
it go, you can let it go, when you get there.
yeah, and think about how like smart, people, they make us like the redheaded stepchild sometimes. But listen, when we're dealing with the red, listen to how smart your sphincter is, if you ever think about
Yeah.
it.
Yeah.
When it's time, when something goes down there and gets near the rectum, and you have to decide when it's go to the restroom. Most times, can't you tell when it's, oh, it's just gas, so I'm just gonna pass gas, or
Mm-hmm.
oh wait, this seems like it might be more, or you know what,
Right.
ooh, this might be liquid, this might be
Right.
diarrhea, or this may be
Right.
like, think about it.
It's
Your
really
sphincter
smart.
muscle can
Yeah.
really detect, your body can kind of sense. Now, sometimes, if you got a stomach bug or this and that, it may go awry, but I mean,
Mm-hmm.
like you really can tell the difference and hold back when it's gas versus solid stool or
Mm-hmm.
whatever. So that's
Mm-hmm.
just how smart that system is and how
Mm-hmm.
complex it is. And then,
Mm-hmm.
and then as you were mentioning the mixed situation, when I get the full story from a patient, number one, I have to tell them like, we're not gonna make you perfect. Okay.
Right.
Like so let's level set. If
Mm-hmm.
there are one or two things that you would be like, if I could fix this or just do this,
Mm-hmm.
that you would totally be a happy camper,
Mm-hmm.
what would that be? So
Mm-hmm.
we may not be able to slow down how often you go to the bathroom, but maybe we can slow down that urgency. Maybe we can give you a little bit more time to wait so you can
Mm-hmm.
leave the house. Now, you
Mm-hmm.
maybe only make it to the QT, 5 miles away, but you can
Mm-hmm.
leave the house. So you may
Yeah.
know where every restroom is along your path, but you can make it to the restroom. You can reliably. So,
Mm-hmm.
those are the things that we really have to also is just make sure that we discuss with patients like what their goals are, what is going to improve their quality of life, and be realistic on what we may be able to improve upon so they can just kind of know in their mind what to settle on. So, so
Yeah.
many people, now we're in the Bible Belt. I'm Christian, raised Christian. We're in the Bible Belt, and so many women come to me, they're like, I just want to go to church. Like
Mm.
I just want to be able to sit through a church service on a
Yeah.
Sunday. And so that
Mm-hmm.
that's a big deal,
Mm-hmm.
Yeah.
Yeah, and I love what you said, right? It's so important to set expectations, right? And I think that, that's something that I spend a lot of time talking with my patients about. There are some things, as we discussed, that maybe can be fixed, right? If you have a mass or a fibroid or something that's pressing on something and causing trouble, there may be a surgical intervention that can make that go away, right? But oftentimes when we're dealing with neurologic disease, we are dealing with long lasting symptoms. And so we have to look at the goal, maybe not to be where we were, okay, but with this new us, how can we optimize and be the best that we can be where we are? And I think that that is so key because one of the reasons that I see many treatments fail in a sense is because of the expectation, and I'm like, listen, particularly with, let's say, with multiple sclerosis or neuroimmunologic
Right.
disease, our medicines don't fix what's already broken. We try to prevent new things from being broken. But inevitably, no matter how much I drill it, when people come back in 3 months, they say, I don't feel better. And I say, I never told you was going to feel better, sugar. I just want to know, do you not feel worse? And so setting those expectations and trying to find reasonable things and goals that are achievable is
Yeah.
really important because ultimately our goal is always we want people to be able to enjoy some of those things. If we can get you to church, we would love to get you to church. Now, we may not be able to get you to sit through like, a 5 hour movie. Now, we may not be able to get you to sit through the 5 hour
Right.
church service, right? You may have to
Right.
go to the hour
Right.
and the 90 minute, right? The
Right.
60, ninety
Right. The
minute
Bible
service,
study. Yeah, so
right?
just
You
do a
may need
Bible
to go to
study, but
Bible
yeah.
study, but we're going to do our best to get you there in some capacity. And so
Yeah.
I think that that's a really key part of this is, setting those expectations up front, checking in and making sure people are aware. And, I think also that shared decision making is important. Having people be a part of that process so that, this is what we decided to do. You own it.
Yep.
So let's follow through with it. And then let's check back in and see if it's working or if it's not working or what we need to adjust.
Perfect. Perfect.
Yeah.
Um, So we're gonna wrap up our session tonight. It's been amazing speaking with the nerdy neurologist, and just that mashup with the nerdy neurologist and the love below, and just really understanding,
Hey.
a just really understanding the impact of, different bodily functions and dysfunctions on the other body systems. And so,
Yeah.
if you have some parting words for us this evening, the nerdy neurologist, what would you say? And she froze. She froze on me. Okay, hold on. Hold on. Okay.
Oh, I
All right.
froze. Okay, can you hear me
There we
now?
go. Let's go
Yeah.
back.
So my
Okay.
parting words would be, don't be afraid to speak up. Many times, particularly with, chronic disease, no matter what it is, people are very shy or scared to talk about their bowel or their bladder, and they don't want to talk about sexual dysfunction. And these are things that really impact daily life. So I would say, don't be afraid to talk to your doctor about these issues, because it is important. And know that you don't have to suffer, right? Some people are like, well, I just been peeing on myself for 20 years and I thought I just had, and I'm like, well, who said we couldn't do anything?
Right.
So at
Right.
least try. Speak up, let somebody know that it's impacting you. I have a quote at the bottom of my email that says, the man who conceals his disease can never be cured. And so a closed mouth don't get fed. We can't
Yep.
help you if we don't know it's a problem. So that would be my admonition
Exactly.
to the people.
Exactly. Well, thank you so much. So, we are going to sign off of this episode of the Love Below series. We look forward to having you back again in the future,
Absolutely.
and stay tuned. I think we're going to take a week off next week, and then we're going to follow up after that with Dr. Lisa, the body snatcher, who is going to talk to us about how the Love Below and cosmetics and aesthetics, can impact our quality of life as well.
Thank you
Bye
so
for
much for
now.
having me.
You're welcome. Bye bye.
Bye.